How's it going, guys? Past level question for hematology, step 1 internal medicine, 2 CK, 49-year-old man, form with history of fatigue. Then we have this very buzzy image here, which I'll talk about as we move through the question. Which additional finding most likely see in this patient? Choice A, C10 positive cells, wrong fucking answer, refers to acute lymphoblastic leukemia, ALL, which on USMLE 9 out of 10 times is going to be a school-age kid who has a super elevated leukocyte count, generally 30,000 or greater, and it's going to be almost all lymphocytes. Okay, so they'll give you 8-year-old boy, 6-month history of fatigue, lymphadenopathy, leukocyte count 40,000, it's 90% lymphocytes. That's ALL. Okay, it can be CD10, TDT positive. And the caveat is that pertussis can cause reactive lymphocytosis where it can look like ALL. So they can give you a kid, same deal, 90% lymphocytes, leukocyte count 40,000, but he's got whooping cough. And he's got post-tussive emesis. And he's got hypoglycemia. Obviously, that's pertussis, not ALL. It's a caveat. You got to be mindful of that important differential for 2CK peds in particular. ALL, wrong fucking answer. Choice B, CD15-30 positive cells, wrong fucking answer. Refers to Reed-Sternberg cells, Hodgkin lymphoma. Okay, so they're B cells with an owl eye appearance under light microscopy. 100% of questions, you're going to get either a teenager or a young adult who has painless lateral neck mass / facial swelling, which is lymphadenopathy, okay? And then they're going to give you an additional findings such as mediastinal mass, which is not thymoma, it's mediastinal lymphadenopathy. They can tell you hepatomegaly, they can tell you troisier sign of malignancy, which is your left palpable supraclavicular lymph node, or Virchow node, aka pronounced Virchow but spelled Virchow, need not be gastric cancer, okay? Hodgkin's, wrong fucking answer. Choice C, greater than 10% plasma bone marrow biopsy, wrong fucking answer versus multiple myeloma. So multiple myeloma, you're going to have your characteristic age 50 plus patient, mid back pain, hypercalcemia, lytic lesions, high ESR with rouleau formation, going to have high MCV, Bence-Jones proteinuria. Okay, a lot of buzzy stuff going on. So first step in diagnosis for 2CK, serum protein electrophoresis showing an IgG kappa lambda M protein spike. Okay, they're immunoglobulin light chains. So you get cardiac amyloidosis, renal amyloidosis, and then your confirmatory test after the serum protein electrophoresis is going to be bone marrow biopsy showing greater than 10% plasma cells. If it's under 10%, that's going to be monoclonal gammopathy of undetermined significance. It's MGUS. If it's on the cusp, it's called smoldering myeloma. Point is, wrong fucking answer. Choice D, 50% blast, correct answer. Diagnosis AML, acute myelogenous leukemia. Very buzzy image of our rods here. Okay, so you can see these needle-shaped structures. Don't worry about different subtypes, M2, M3, etc. USMLE doesn't give a fuck, okay? You're just going to get a standard AML question. It can be acute promyelocytic leukemia, M3, obviously 15-17 translocation, but as I said, USMLE doesn't give a fuck. I'm just articulating that because you have some pedantic students who are going to get salty if I don't mention every little fucking detail. Point is, it's AML, okay? And there's two ways they're going to assess AML on USMLE. The first is this. They're just going to show you the IRODs, ultra easy. Second way they're going to do it is they're not going to show you the image, and then they'll tell you that some kid's got some sort of leukemia going on. Sorry, not a kid. Kid is ALL. Some patient has some sort of leukemia going on, generally adult, and they're going to say there's 30% blasts, 50% blasts. That's it. That's all they're going to do, okay? And you just got to know that that's AML. I'm going to talk about the others as we move through, all right? So I said a moment ago that ALL is going to be a kid who's got high leukocytes where it's all lymphocytes, okay? And you got to be mindful it's not pertussis. It's an important differential. AML, 30-50% blast, you get RODs. So let's just keep moving through. Choice C, reactive granulocytosis, wrong fucking answer, refers to leukemoid reaction, which is a very confusing diagnosis. Students will hear that phrase, that diagnosis thrown around a lot, but they still don't know what it is. I'll make it very fucking clean and easy for you. Leukemoid reaction is when you have an infection that causes an exaggerated immune response where you have leukocyte count greater than 30,000. That's it, okay? So normal leukocyte count, 4 to 11,000. And if you have a general infection, let's say pneumonia, maybe you'll have a leukocyte count that's normal. It can be normal, okay? You can have a leukocyte count that's 13,000, 18,000. You have sepsis, ruptured appendix, maybe you have a leukocyte count of 23,000. So if you have a leukocyte count that's 30,000 or greater, it can look like leukemia, okay? So OID, OID means looks like but ain't. So when you initially see the WBCs 30,000 or greater, you're like, holy shit, maybe this patient has leukemia. But then when you do the blood smears, you see that You don't have leukemic cells there. You have granulocytes, which is just another way of saying neutrophils. Okay, granulocytes refers to neutrophils, eosinophils, basophils, but it's essentially just synonymous with neutrophils and USMLE. So you have neutrophilia, reactive granulocytosis. Okay, in contrast, if you have low neutrophils, that's neutropenia or agranulocytosis, such as with clozapine, etc. So reactive granulocytosis is one of the ways they write leukocyte reaction on NBME. They can also, they want the mechanism sometimes, which is going to be, quote, increased leukocyte release from bone marrow post-mitotic reserve pool, okay? And you're gonna have a smear that shows neutrophils. In this case, wrong fucking answer. Choice F, smudge cells, wrong fucking answer versus CLL, chronic lymphocytic leukemia. Okay, it's going to be an adult who's got elevated leukocyte count where it's all lymphocytes. So I said a moment ago that ALL is going to be a kid who has a leukocyte count that's super elevated where it's all lymphocytes. Give the same fucking vignette, except rather than a kid, you give a 65-year-old. That's going to be CLL. Okay, smudge cells, truthfully, ultra low yield. It's just buzzy. I think there might be one question ever in history floating around where smudge cells are actually part of the question. But they want you to know for CLL, actually, that quantitative immunoglobulin assay is one way to diagnose it. That shows up on a difficult 2CK question. I've actually made a prior YouTube clip talking about that. But that's going to be CLL. Okay, so super elevated leukocyte count, all lymphocytes, but in an adult, not a kid. And then for finally 922 translocation, wrong fucking answer versus CML, chronic myelogenous leukemia, where you're gonna, this is the Philadelphia chromosome, which codes for it's BCR-ABL tyrosine kinase. It's an oncogenic tyrosine kinase. It's a fusion protein. That's one of the ways they can write it. And CML, you're gonna have myelocytes, promyelocytes, metamyelocytes, all these myelo-sounding cells down the center of the page for the question when you get it, okay? So that's how we differentiate these leukemias. You can have a low leukocyte ALP for CML where it's an elevated, whereas it's a leukocyte ALP that's elevated with leukocyte reaction. You treat CML with imatinib, which is a drug that targets BCR-ABL tyrosine kinase, can cause fluid retention / peripheral edema. Wrong fucking answer. You know the deal. I'm just to make more content. If you look at subscribe channel. Appreciate your time. That's it.